Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Am I audible and visible? All right, great. So this is a quick revision of the topic of porphyria, like the timetable that we are following on the Telegram group. So in the daily targets, it is the subject of biochemistry that is going on. And today you have in the daily target the topic of porphyria and the topic of enzymes. And I know that being through this journey, I know that porphyria is one topic out of all the 19 subjects. If I ask, porphyria is one of the common topics which is dreaded by many students, right? So I'll try to simplify this topic in next 15 minutes. That is what our target is. Taki quickly I tell you the tricks on what are the points to be focused on in porphyria, then you can solve the MCQs from the question bank or the guidebooks, and I'm sure this will help you in remembering porphyria for a long time. All right, so let's start with that. Before that, tell me how many of you find this topic difficult, or you were having this topic of porphyria in the today's target and you were like कि कोई इसके tricks बता दे that how do I read this topic, or how many of you had actually thought कि let's skip this topic, कितना भी बार पढ़ लो, we are not able to remember this topic. Right, so in the remaining days of biochemistry as well, in the targets that we have, we are going to do a lot of biochemistry MCQs, tricks and mnemonics, right? So I'll try my best to help you in the subject of biochemistry, and whoever finds it difficult, I can see quite a few of you. Please let me know after the session in the comments whether this session helped you in remembering this topic. Okay, so let's dive into this topic of porphyria, right? So what is porphyria basically? First, let us understand that. Porphyria basically is a problem with the heme synthesis. Okay, there is some step in the heme synthesis that is affected. What do we require this heme for? Where is this heme required? Basically, heme will be required for hemoglobin, and where else this heme is required? The porphyrin ring, basically, where is it required? It is required in the cytochrome as well. Okay, it is required in the cytochrome as well, right? So if there's a problem in the heme synthesis, the intermediates accumulating, basically that is what causes porphyria. So porphyria is increase in the porphyrins, basically, which is the intermediate for heme, right? Basically, which is the intermediate, the precursors for heme. So in the porphyria, first of all, tell me that where does heme synthesis occur? In what part of the cell does the heme synthesis occur? Does it occur in the cytoplasm? Does it occur in the mitochondria? Where does it occur? Heme synthesis, remember, are mnemonic, the cycles which occur in both cytoplasm and mitochondria. Hug, right? Whenever we hug someone, we hug with both the arms. So it is hug which takes place in both. So remember here the H is basically for the heme synthesis. It is not for the HMP pathway. HMP pathway takes place in the cytoplasm. Heme synthesis occurs in both mitochondria and in the cytoplasm, right? So which enzymes are mitochondrial and which enzymes are cytoplasmic? So there are 8 enzymes basically in the heme synthesis. Okay. So remember 1, 2, 8. So basically the first one is mitochondrial, and then the last 3 are mitochondrial. Beach ke 4, 2, 3, 4, 5, these are cytoplasmic. Okay. So basically it starts in the mitochondria. Then it goes into the cytoplasm, comes back to the mitochondria. So it is both mitochondrial and cytoplasmic. If I ask you what is the rate limiting enzyme for heme synthesis, it is the first step, which is the step of ALA synthase. Okay, the first step, that is ALA synthase, that is the rate limiting enzyme. Now, what does this ALA synthase require? Another important question. Remember, it requires B6 vitamin, and you can see it's a mitochondrial enzyme. Okay, remember all these points are very, very important. So it requires vitamin B6. That is why pyridoxine is very, very important. Right, for heme synthesis, there is pyridoxine deficiency. One of the manifestations of pyridoxine deficiency, you have sideroblastic anemia which can occur, right? Sideroblastic anemia, pyridoxine deficiency. Then it is a mitochondrial enzyme, ALA synthase. What amino acid is required? It is glycine, very, very important. Which TCA Krebs cycle intermediate is required? It is succinyl-CoA. Okay, so remember the first step, that is glycine and succinyl-CoA ALA synthase. It forms your ALA, that is delta aminolevulinic acid. Okay. What does G stand for in HUG? Kahani, it stands for gluconeogenesis. U stands for urea cycle, G is gluconeogenesis. Okay. So now the ALA is formed. Then comes the next step. Now it is going to be cytoplasmic. ALA is formed. The next step is ALA dehydratase. Remember, ALA dehydratase is like dye. So remember dye, that is the second step. Okay. And this is the one which is inhibited by lead. So remember, lead inhibits DE, that is ALA dehydratase, and it also inhibits ferrochelatase. Okay, it also inhibits ferrochelatase. So then it forms porphobilinogen, right? Then it forms porphobilinogen. Now you have the next very, very important enzyme, that is porphobilinogen deaminase. Just listen to this, whatever we are discussing. Every word is important. Stay till the end. Towards the end, the entire topic of porphyria will be easy. Okay, so but you need to listen very attentively. So porphobilinogen deaminase, okay, which is also called as HMB synthase, hydroxymethylbilene synthase. Why? Because it is forming HMB from porphobilinogen. So basically the deamination of porphobilinogen is forming HMB. What is this also called as? What is the other name for this enzyme? This hydroxymethylbilane spontaneously gets converted to uroporphyrinogen 1 spontaneously. So this is also called as uroporphyrinogen 1 synthase. Okay, it is also called as uroporphyrinogen 1 synthase. So if there is a defect at this step, what porphyria it leads to? Very, very important, acute intermittent porphyria, that you must have heard. Acute intermittent porphyria. So remember that acute intermittent porphyria, I, intermittent is 1. So remember, it is uroporphyrinogen 1 synthase which is deficient in AIP. AIP, this enzyme is also called as, remember the names of the enzymes, PIH. Pregnancy-induced hypertension, PIH. Okay, AIP, remember, is PIH. That is porphobilinogen deaminase, uroporphyrinogen 1 synthase, or it is HMB synthase as well. Okay, these are the various terms for the same enzyme that is deficient in acute intermittent porphyria. Other important points for acute intermittent porphyria. Is it autosomal dominant or is it autosomal recessive? Tell me, is it autosomal dominant or is it autosomal recessive? Remember that majority of the porphyrias, they are autosomal dominant. We will come to this point. We will revise this mnemonic again, that the erythropoietic porphyrias, erythropoietic, ER is AR. Those are the ones which are autosomal recessive. Okay, ER is AR and also the ALA dehydratase wala. Okay, we will see that. So remember, this is autosomal dominant. Another question, does it have neurovisceral symptoms? Does it have cutaneous symptoms or does it have both? Acute intermittent porphyria. Is it neurovisceral? Is it cutaneous? Or is it both? Remember, intermittent. Okay, intermittent is like internal. Okay, there are internal manifestations only. There are no external manifestations. That means there are no skin lesions in acute intermittent porphyria. It is only neurovisceral, neuropsychiatric symptoms, and the liver is affected, right? The liver is affected. There is abdominal pain, tachycardia, liver affected, brain affected, neuropsychiatric. Okay. Remember, only internal manifestations are seen. So look at the important points. It is autosomal dominant, late onset. Intermittent means there is episodic expression. There is anxiety, confusion, that is basically neuropsychiatric, abdominal pain. Remember, there is no photosensitivity. Very, very important. No cutaneous manifestations. There can be port wine urine in some patients, and you should never give barbiturates in porphyria. Very, very important. Remember that barbiturates can precipitate porphyria, so they are contraindicated. Why? Because barbiturates, phenobarbital, they are enzyme inducer, cytochrome P inducer. So they will induce the cytochrome production. If cytochrome has to increase, heme also has to increase, right? The heme pathway has to increase. So that will precipitate the intermediate. So that will precipitate porphyria. Okay. So remember, barbiturates are contraindicated. Very, very important. Okay. Now going to the next one, uroporphyrinogen 1, that was HMB. Now you have uroporphyrinogen 3. Okay, that is basically uroporphyrinogen 3 synthase is the enzyme. In the porphyrins, remember, first you have U, then you have C, and then you have P. That is uroporphyrinogen, coproporphyrinogen, and then you have protoporphyrin. So remember UCP. Okay, remember UCP. First is uro, then is copro, and then it is proto. Okay, then it is proto. All right. So uroporphyrinogen gets converted to coproporphyrinogen by which enzyme? It is decarboxylase. So remember, this is not aminase, it is carboxylase, which forms your coproporphyrinogen. The decarboxylase forms coproporphyrinogen, right? And then you have protoporphyrin, and then you will have ferrochelatase. As the term says, ferrochelatase, it is chelating the ion into protoporphyrin. That is what basically is forming heme. Okay, that is what is forming heme. So the other very, very important enzyme here and the most common porphyria is Porphyria cutanea tarda. As the term says, it is cutanea. So there will be cutaneous manifestations. There will be photosensitivity. There will be blistering skin lesions. Dorsum of the hands are very, very important. It can be, exacerbated by alcohol. This is the one where you have a lot of external conditions which can lead to porphyria, like even hepatitis C, vagera, alcohol, all this can cause Porphyria cutanea tarda. It can come sporadically also, right? So remember, even this is autosomal dominant and it's the most common. Let's again revise this, learn the mnemonics here. Now basically, which is autosomal dominant, which is recessive, which is neurovisceral, and which is cutaneous. Okay, let us learn that. We'll revise this 2 to 3 times so that this topic gets ingrained in our brains forever. Okay. So which is autosomal dominant, or rather which is autosomal recessive? What did we learn? All the erythropoietic porphyrias are autosomal recessive. So you have congenital erythropoietic porphyria, you have erythropoietic protoporphyria. X-linked protoporphyria itself tells you it is X-linked, it is not autosomal. And the ALA dehydratase. Remember dehydratase wala, that's a misnomer. Dehydratase is not dominant, it is recessive. Okay. The rest of them are autosomal dominant. Intermittent, cutanea tarda, HCP, coproporphyria, variegate, these are dominant. Okay. So remember, 4 are autosomal dominant, 3 are autosomal recessive, and 1 is X-linked. Which porphyria or which enzyme deficiency leads to X-linked porphyria? The first one, the rate limiting enzyme wala, ALA synthase 2. Okay, remember it is ALA synthase 2 that basically leads to your X-linked protoporphyria. It is ALA synthase 2. Okay, ALA synthase 2. Then the next that you have autosomal recessive is erythropoietic, and you have the ALA dehydratase wala. Okay, ALA dehydratase wala. Okay. Now, which is neurovisceral and which is both? So, cutanea tarda, as the term tells you, it is cutaneous manifestations. Okay, it is cutaneous manifestations. The ones where you have both neurovisceral and cutaneous. So, basically remember, it is combined manifestation. or it has various manifestations. That is how you can remember. So combined is basically C and various is V. That means the coproporphyria and the variegate porphyria are the ones where you have both manifestations. So coproporphyria and variegate are the one where you have both cutaneous and visceral. Okay, so C and V, cutaneous and visceral, combined various manifestations. They have both coproporphyria and variegate porphyria. Right? Why am I telling you this? Because in the clinical scenario, depending on whether it is just neurovisceral, whether it is just cutaneous, or whether it is both, you will be able to narrow down and rule out the options. Okay. So remember, CV is the one which is both combined and various. It has both the manifestations. Intermittent porphyria is only neurovisceral. Okay. The other porphyria which is only neurovisceral is your ALA dehydratase wala. That is lead wala, the ALA dehydratase deficient porphyria. Okay. So even that is neurovisceral. Okay. Let us go to this one. So how will you differentiate the ALA dehydratase porphyria from the acute intermittent porphyria? What are the differentiating points? If I tell you ADP and AIP, the dehydratase and the acute intermittent, both are neurovisceral, only. So what are the points that I should look for to help me differentiate the two? One, this is autosomal recessive, this is autosomal dominant. Second, this is due to deficiency of ALA dehydratase. That means after ALA, this step is inhibited. So there will be increased in ALA, right? There will be increase in ALA. Porphobilinogen will not be formed. Porphobilinogen will be less. While in acute intermittent porphyria, it is after this step which is inhibited. So the porphobilinogen will also be high. Okay, that is the differentiating point. So look at this one. In ALA dehydratase, in the spot urine, there will be increased ALA and normal porphobilinogen. In acute intermittent porphyria, the porphobilinogen will be high. Okay, that is how we should be differentiating the ADP and the AIP. Whenever you get increased porphobilinogen, it is AIP. Okay, it is AIP. Now, also remember at this point that all the erythropoietic porphyrias are cutaneous manifestations. Remember, erythro matlab red, erythro matlab red. So basically remember that causes the red skin. So all of those are cutaneous. Okay, all of those are cutaneous. Okay. So in the cutaneous ones, which are blistering skin lesions, which are non-blistering skin lesions. So remember, the protoporphyrias are the ones which are non-blistering. Which are the protoporphyrias? The first step, X-linked wala protoporphyria, and the last step wala. Okay, and the last step wala, that is ferrochelatase wala, erythropoietic protoporphyria. Okay? So these are the ones which are non-blistering. Porphyria cutanea tarda is blistering. Okay, that is blistering. Now going to the next one. Okay, now let us revise whatever we have learned so far, the very important points in porphyria. Okay, what did we all learn so far? Okay, what did we learn here? So, are you able to read it now? So the first step, remember, this is mitochondrial ALA synthase, glycine and succinyl-CoA. And if there is a problem with this enzyme, then it leads to X-linked protoporphyria or X-linked sideroblastic anemia. Gain of function mutation, loss of function mutation. Second, dehydratase wala is the second one. It is autosomal recessive. Third, acute intermittent porphyria is uroporphyrinogen 1 synthase, right? Also called as PBG deaminase or HMB synthase. They mean the same. Then you have uroporphyrinogen 3 synthase, which basically is what porphyria? Congenital erythropoietic porphyria. Remember, congenital, C is the third alphabet. It is uroporphyrinogen 3 synthase. Okay, 3 synthase. Porphyria cutanea tarda, C wala, it is decarboxylase. Uroporphyrinogen decarboxylase. there's a problem with coproporphyrinogen synthesis. Next is the oxidase. Coproporphyrin gets accumulated. It leads to hereditary coproporphyria. Then you have the protoporphyrinogen which is formed. Again, oxidase. That is variegate porphyria. Remember, variegate is at the last. It is protoporphyrinogen oxidase. And the last one is basically ferrochelatase, which is erythropoietic. Now, ferro is coming, iron is coming into basically the heme. RBC wala erythropoietic, protoporphyria coming at the end. So the last three are mitochondrial. The first is mitochondrial. The rest are basically cytoplasmic. Okay. Let us complete this table now, everyone. What is the enzyme deficient in X-linked? It's not deficient, rather increased here. It is ALA synthase. ADP is dehydratase. AIP is uroporphyrinogen 1 synthase. Congenital is uroporphyrinogen 3 synthase. PCT is uroporphyrinogen decarboxylase. Coproporphyria, it is the oxidase which is affected. Uroporphyrinogen oxidase, coproporphyrinogen. Coproporphyria is happening. Variegate porphyria, what is the enzyme deficient? Protoporphyrinogen oxidase. And the erythropoietic, the last one is ferrochelatase. Okay, the last one is ferrochelatase. Inheritance, X-linked is going to be X-linked. AD is a misnomer. It's not AD, it is AR. AIP is autosomal dominant. Erythropoietic is autosomal recessive. Cutaneous tarda is dominant. HCP is dominant. VP is dominant. EPP, again erythropoietic, is autosomal recessive. So 3 are autosomal recessive, 1 X-linked, and 4 are dominant. Neurovisceral cutaneous, ADP and AIP are neurovisceral only. All erythropoietic will have the cutaneous manifestations. Cutaneous tarda is cutaneous, right? And HCP and VP are the one which have both combined and various manifestations. Okay, they have combined and various. So remember, combined and various are both the manifestations. Okay, they are both the manifestations. All right. Now, going to the next one. Now, this is a common image that you would see in the questions in the exam. So, on the dorsum of hand, the skin lesions, blistering wale, that is commonly porphyria cutaneous tarda, which is the most common porphyria in adults. What is the enzyme deficient? Uroporphyrinogen decarboxylase. Okay, that's decarboxylase. Tell me what will be the answer to this one? 2-3 MCQs and we are done with this topic. Acute intermittent porphyria. Remember, intermittent is I, it is uroporphyrinogen 3 synthase. You also have PIH, that is porphobilinogen deaminase and HMB synthase. Okay, and HMB synthase. Uroporphyrinogen 3 synthase is congenital erythropoietic porphyria. Ferrochelatase is the last one, erythropoietic protoporphyria. Okay, which of these is not autosomal dominant? Answer to this would be, which of these is not autosomal dominant? AR is ER, right? So all the erythropoietic ones are basically AR. So remember, it is erythropoietic protoporphyria, which is not autosomal dominant. Okay, very, very important. Next one, porphyrias absorb light in the wavelength of 400 nanometers. Another point, that is something called as the Soret band. So they show a peak at 400 nanometers. They absorb the light. That is called as Soret band, used for the diagnosis of porphyria. So look at this one, 400 nanometers. You get a peak. That is Soret band. It is the ultraviolet visible absorption spectrum of porphyrin. Other test for porphyria is the Ehrlich test, and you have the Watson test, which are also used. Okay, which are also used. Okay. So yes, that was the summary, the quick summary of the topic of porphyria. Write it down on one sticky note on one page, all the tricks that you have learned from porphyria. Keep it in front of you so that you keep revising and this topic is done and dusted, right? So the majority of the points have been covered, except for the few extra points like the Gunther's, the erythrodontia is erythropoietic porphyria and all of that. Okay, so thank you so much everyone for joining in. That was it for this quick porphyria topic revision, and I'll see you again tomorrow at 12 p.m. for the special class on Unacademy. Till then, goodbye, take care, and keep studying, keep revising.